আজকে মিজেলস আর মাম্পসটা আমরা মোস্টলি কভার করব, ঠিক আছে। ফার্স্ট টপিক মিজেলস, ভ্যাকসিন প্রিভেন্টেবল ডিজিজের আন্ডারে এগুলো পড়ানো হয়। মিজেলস পজিটিভ এজেন্ট হচ্ছে আরএনএ ভাইরাস হুইচ বিলংস ফ্রম প্যারামিক্সোভাইরাস ফ্যামিলি, Paramyxoviridae or Paramyxoviridae, okay. It is transmitted by droplet spread from nasal and throat secretions, and the infective period is 4 days before and 5 days after appearance of rash, ঠিক আছে। তাহলে র্যাশ বেরোনো 4 দিন আগে আর 5 দিন পরে, এই পিরিয়ডটা হচ্ছে ইনফেক্টিভ পিরিয়ড। আইসোলেশন ইজ নিডেড ফর দ্যাট পিরিয়ড, ঠিক আছে। দেন এসএআর, সেকেন্ডারি অ্যাটাক রেট ইজ 90%। সেকেন্ডারি অ্যাটাক রেট কাকে বলে? ফর্মুলাটা কি ছিল? সেকেন্ডারি অ্যাটাক রেটের একটা ফর্মুলা ছিল, হাউ টু ক্যালকুলেট। 90% ক্যালকুলেট করেছেন কিভাবে? নাম্বার অফ এক্সপোজড পারসনস হু উইল ডেভেলপ দ্য ডিজিজ উইদিন দ্য রেঞ্জ অফ ইনকিউবেশন পিরিয়ড ডিভাইডেড বাই টোটাল নাম্বার অফ এক্সপোজ পারসন, ঠিক আছে। যতজন এক্সপোজ হচ্ছে তার মধ্যে কতজন ইনফেক্টেড হচ্ছে, সেটাই হচ্ছে অ্যাটাক রেট, সেকেন্ডারি অ্যাটাক রেট মাল্টিপ্লাইড বাই 100। তো সেকেন্ডারি অ্যাটাক রেট 90%, ঠিক আছে, মানে 10 জনের মধ্যে 9 জনেরই হবে। দেন ইনকিউবেশন পিরিয়ড মিজেলসের 10 ডেজ, ঠিক আছে। আচ্ছা, কিভাবে হচ্ছে প্যাথোজেনেসিস? ফার্স্ট, the virus spread by droplet, then it enters the host by respiratory route, okay. Then viral replication in respiratory epithelium. Viruses will multiply and infects local lymphatic tissues, that is primary viremia, okay, that occurs in day 2 to 3. Then again amplification of virus in regional lymph nodes, and subsequently reticuloendothelial system will be infected, that is secondary viremia, that will occur in day 5 to 7. After that systemic symptoms will appear. So first primary viremia at day 2 and 3, then secondary viremia at day 5 to 7. Clinical features, how the patient will present to us. First, prodromal phase, some non-specific symptoms like fever, rhinorrhea, conjunctival congestion, dry hacking coughs, okay, and then Koplik spots, ঠিক আছে। This is pathognomonic of measles. On day 2 or 3, we will found grey white sand-like lesions with surrounding erythema, okay, opposite the lower second molar on the buccal mucosa. Grey white lesions surrounding erythema, okay, opposite the second molar on the buccal mucosa, that is Koplik spots. The specific pathognomonic of measles, okay. And rash, it's very important. On which day after fever rash will appear? On day 4, and with subsequent rise in temperature. Characteristics of rash: first macular and then maculopapular, okay. First macular rash, where behind the ears, along the hairline and on the posterior aspect of cheeks. First macular rash will appear in these locations. Then maculopapular, it will spread to face, neck, chest, arms, then trunk, then thighs and legs, okay. First face, then neck, then chest, then arms, then trunk, then thighs and legs. Okay. It will spread in this order. What is modified measles? Seen in partially immune individuals. Symptoms are of milder variety and duration of illness will be shorter. Okay. This is mild variety of measles and this is severe variety, that is hemorrhagic measles. In hemorrhagic measles, purpuric rash will be there and bleeding from the nose, mouth, bowel. Okay, that's why the name is hemorrhagic measles, and it has severe complications like altered sensorium, convulsion, coma. Okay, maybe death. Achha, this is the type of rash, morbilliform rash of measles. Okay. We can diagnose measles clinically, okay, by seeing the rashes, on which day the rash is coming after fever. Okay. What are the complications of measles? Mainly complications will be in একটু আস্তে যারা যেতে চাও যেতে পারো, কোনো অসুবিধা নেই, অ্যাটেন্ডেন্স পেয়ে যাবে, সাইলেন্ট থাকো। তো কমপ্লিকেশন কিসে হবে? মোর ইন ভেরি ইয়াং চিলড্রেন, malnourished children and immunocompromised children. So what are the complications? Most common is otitis media and bronchopneumonia. Bronchopneumonia mainly caused by which organism? Pneumococcus, Staph aureus, also Haemophilus influenzae. Okay. Other complications are laryngitis, tracheitis, bronchitis. Also, there may be chances of flaring up of latent tuberculosis infection. What are the GI complications? Gastrointestinal, diarrhea, hepatitis, appendicitis, and in few cases acute encephalitis. SSPE, subacute sclerosing panencephalitis, very specific but rare complication of measles. It is degenerative CNS disease and results from persistent measles infection. Mean incubation period of SSPE is 10.8 years. So it will develop in later age. What are the features? Characterized by behavioral and intellectual disorientation, myoclonic epilepsy, dystonia, rigidity, coma. Okay. Patient will come in with intractable seizures, okay, in very bad condition. Diagnosis, mainly clinical diagnosis. Okay. What WHO said, that measles is clinically diagnosed in a person presenting with fever and maculopapular rash and cough coryza or conjunctivitis. Okay. And day of appearing rashes is also important, day 4 of fever. In complete hemogram, we will found low total count, total leukocyte count with relative lymphocytosis. Okay. And specific diagnosis is IgM anti-measles antibody we have to test, that will be positive. Okay. But commonly it is clinical diagnosis. Treatment is viral, so mainly supportive like antipyretics, warm, gargle, okay, and vitamin A. Vitamin A, as per WHO, 2 doses of vitamin A is needed 24 hours apart, okay, and manage complications according to the complications, encephalitis or whatever complications will be there. Transplacental immunity. Measles antibodies transferred from mother to fetus that will give protection to fetus for first 6 to 9 months. It may interfere with live measles vaccination. That's why we first give the measles vaccine at 9 months age. Before that, already protection is there. Okay. So, measles containing vaccine, that is, we give 0.5 ml in subcutaneous route. Site is right upper arm or anterolateral thigh. Schedule, first dose is 9 to 12 months and second dose is 15 to 24 months. We can give MMRV, that is measles, mumps, rubella and varicella combined vaccine, but it is not recommended below 2 years of age. After 2 years of age, we can give all these vaccines together. Otherwise, at 9 to 12 months and 15 to 24 months, we can give normally in national immunization schedule, we give MR vaccine, but in IAP, we give MMR vaccine, measles, mumps, rubella. Then mumps. Mumps also caused by RNA virus, same Paramyxoviridae family, mainly occurs between 5 to 15 years of age. Infants rarely affected. Again, infants are protected by transplacental transfer of antibodies. SAR, secondary attack rate 80%. Again, it is highly infective. Incubation period 2 to 4 weeks. First, spread from the infected person by direct contact or airborne droplets or fomites contaminated by saliva and urine. Then viral replication occurs in respiratory epithelium. Then virus enters the circulation, then reach glandular and neural tissue and affect or targets salivary glands, CNS, pancreas, testes, heart, liver, kidney, thyroid and joints. So, mumps affect many organs. Okay. What are the clinical features? First, prodromal phase. Patient will come with fever, malaise, headache. Then unilateral or bilateral parotitis with complaint of earache, jaw tenderness while chewing and swelling at the angle of jaw. Then epididymo-orchitis in adolescent boys or post-pubertal men. It will occur or happen 1 to 2 weeks after parotitis. CNS complication is aseptic meningitis and other deafness, cerebellar ataxia, transverse myelitis, Guillain-Barré syndrome. Okay. Some uncommon complications are there like pancreatitis, mastitis, ophoritis, nephritis. As I said, mumps affects many organs of our body. So, that's why inflammation of these organs are clinical features or complications. Diagnosis, again it is clinical diagnosis. Serum amylase will be elevated and we can confirm the diagnosis by performing serum IgM ELISA test. Treatment, again it is viral, so supportive management, symptomatic, antipyretics and gargle. Then bed rest and local support in orchitis and mannitol in aseptic meningitis. Okay, mainly supportive treatment. Otherwise, we have to treat every complication according to the complication, ophoritis, pancreatitis, orchitis,